good afternoon, good morning, wherever you are in the world. Welcome to this AReA webinar, which is Andrology Research Academy. And today we're going to be talking about testosterone and prostate cancer. Is there a link? Next slide. I am Professor Hugh Jones. I'm a consultant physician and endocrinologist and honorary professor of andrology in Barnsley and Sheffield in the United Kingdom. Next slide. Here are my declarations of funding for research grants and honoraria. Thank you. Next slide. The aim of the AReA platform is it's a new educational platform that will provide a forum for educational exchange, share the latest research in the field of andrology, and foster interaction with international experts. The sponsor is Besoin Healthcare, and they are committed to continuous medical education to ensure that physicians have the most up-to-date knowledge and can make the best treatment choices for their patients. Next slide. So what are the objectives of the webinar? So the area we're talking about is a subject of much uncertainty. So we'll explore the historical content and basis for the traditional teaching on the relationship between testosterone and the prostate. And we will review and appraise the current evidence base between testosterone and prostatic disease, and hopefully increase your knowledge and understanding of this very important concept in andrology, and explain how this paradigm has shifted in recent years. Next slide, please. This is a product label and disclaimer. Next slide, please. So while viewing the webinar, this is taken from our previous webinar. You will see here that you can go to full screen, click on the button just under the pictures of the presenters, and then you can exit the full screen by pressing escape. So that's important to know at this stage. Next slide, please. So if you want to ask questions, use the chat box here. And you must exit full screen to see and use the chat box with the press escape. So when next slide, please. So we are going to be wanting to evaluate this webinar, and also you will be able to get a certificate of attendance. So the evaluation button is important, and even if you're going to leave the webinar soon, it would be great if you could fill that evaluation form up. So your feedback is so greatly appreciated, so please click on that evaluation button at the top of your screen, and you will receive an email with the for the certificate of the attendance. So keep asking questions, and we will be presenting some of the questions to our speaker at the end. Next slide, please. So first of all, you've had my welcome, and I will now like to introduce Professor Abe Morgenthaler, who is Associate Clinical Professor of Surgery at the Harvard Medical School in the US. So he's a well-renowned speaker, and it's a great pleasure to have him speaking for us today, as he's done a considerable amount on the research and looking at this role between testosterone and the prostate. So I hopefully you'll enjoy a very good talk from a renowned individual. Next slide, please. So Professor Morgenthaler is president of the Androgen Society, and I am president-elect. So this is just to tell you about the Androgen Society. It's the first Androgen Society. So the Androgen Society is the first professional medical society dedicated entirely to testosterone deficiency, hypogonadism, and its treatment. And on there, you'll see the website is quite straightforward, www.androgensociety.org. And we also have a new journal, which is already having publications online, which is called Androgens: Clinical Research and Therapeutics. Next, so this society is trying to bring individuals from different specialities together to talk about testosterone, and that includes not only urology, endocrinology, diabetes, and sexual medicine, but also cardiology, respiratory diseases, HIV experts, testosterone in women, and also anything that testosterone has any relation to in clinical medicine. So we have our third Androgen Society meeting in March, which is going to be a virtual meeting online, and it's scheduled for March the 12th to the 13th. So you will be able to log in and listen to some experts speaking on different interesting specialties related to testosterone, and including these are the effects of androgen deprivation therapy, COVID-19 and testosterone, testosterone in women, diabetes and testosterone, and many others. We're accepting abstracts up until December 31st. Next slide, please. So without further ado, I will transfer you to Professor Morgenthaler for his lecture today. Thank you. So, Professor Morgenthaler.
Well, Hugh, thank you so much for that lovely introduction, and it's a pleasure to be with all of you today. I wish we could all be in person, but who would have believed a year or two ago that we'd all be consumed with a worldwide pandemic? It's unbelievable how it's changed medical education, amongst other things, in all of our lives. I want to talk to you today about something that I've been interested in and working with for the entirety of my professional career, really, which is this relationship between testosterone and prostate cancer. And I want to thank the folks for the Andrology Research Academy and BSAM for providing the platform for this forum. These are my disclosures. And so let's get started. The traditional teaching for more than 75 years is that testosterone has been like the devil with regards to prostate cancer. And you'll see throughout my slides, the T refers to testosterone and prostate cancer is abbreviated as PCA. And I learned this, and I'm sure that all of you learned the same, these bullet points, that high testosterone caused prostate cancer. I learned that low testosterone is protective. For example, men who were castrated early in life were supposed to never develop prostate cancer. I learned that raising testosterone in a man with prostate cancer is like feeding a hungry tumor or pouring gasoline on a fire. And that testosterone therapy is contraindicated, absolutely, in men with prostate cancer, even if they were treated. I learned all of these things. I taught them to my own students and fellows. I'm sure all of you have heard these things as well. And it really became the main reason why testosterone use was exceedingly rare until really fairly recently. And why do we believe these things today? Well, I think there's several reasons. One is that everybody knows that we treat advanced or metastatic prostate cancer with androgen deprivation, ADT. We lower testosterone in those men as much as we can. We use anti-androgens to block the very transient rise in testosterone. We call it testosterone flare, with the use of the LHRH agonists, which are medicines that do lower testosterone. They're used to treat metastatic prostate cancer, but for the first 7 days or so, there can be a rise in testosterone, and we block that. Every label for testosterone product has a warning that testosterone is contraindicated in men with, and in the United States, the labels say even suspicion of prostate cancer is a reason to not use testosterone. And we have in vitro and laboratory evidence that higher androgen concentrations cause greater growth of androgen-sensitive prostate cancer cell lines. So this seems pretty compelling, and this belief has gone on for a long time, and we appear to have modern evidence that certainly is consistent with this. This is how doctors practice medicine with regards to prostate cancer. Essentially, we lower testosterone and keep it as low as we can. And so it seems logical that if we're lowering testosterone to help men with prostate cancer, then raising it must be dangerous or risky. It turns out, as I'm going to show you, that almost everything that we learned about testosterone and prostate cancer, though, turned out to be incorrect. So how I got started with testosterone was a little bit off the beaten trail. I was at Harvard College working in a laboratory as an undergraduate, working with these lizards. This is the American chameleon, Anolis carolinensis. You see a male on the right, a female on the left. When the male sees the female, he has this bright colored flap of skin under his neck. It's called a dewlap. The dewlap comes out. The male bobs his head up and down a few times. If the female is hormonally intact, she'll make a little dainty push-up. The male comes closer, the flap comes out, he repeats his behavior, and they mate. And it turns out that if you castrate these males, remove their testicles, and you put them in a cage with the female, they don't do anything. Their libido, their drive for sex is gone. And my project for 3 years, and my first publication came out in 1978, if you can believe it. Oh my God, makes me feel old. My project was to take tiny amounts of testosterone and put it in specific areas of the brain that we believed were involved with sexual behavior. And even though circulating levels of testosterone were undetectable, if I was successful in getting it into the right parts of the brain, those males would again show their dewlap and do their entire sexual behavior. It was incredible. And so when I came out of my urology residency in 1988, I'd learned a little bit about testosterone, but not much. You know, we knew it was important for pubertal development in men or males. And we knew that if you castrated men, which we did for men with advanced prostate cancer, that they lost their libido, they lost some of their strength. But when I graduated, testosterone therapy was rare, truly rare. And its use was restricted almost exclusively to young men who had major issues, congenital or genetic issues, for example, Klinefelters, those men who had pituitary tumors or tumors that had been resected. And so they didn't have any stimulation of the testicles to make testosterone. Men who had lost their testicles to cancer or trauma. And those few men were treated usually at, academic or tertiary or secondary tertiary medical centers with injections of these relatively short-acting medications, testosterone, cypionate, or enanthate, roughly once a month. And it was known that that helped them develop through puberty, would help them achieve a beard and some degree of sexual function and desire. When they turned middle-aged, people got nervous. And often they would discontinue the testosterone because they were worried about prostate cancer. And in general, that was the big limiting factor with using testosterone in men, which is the fear that it was going to precipitate prostate cancer. And in the late 1980s, we had learned around that time that high percentages of men who had died for other reasons and then underwent autopsy studies, that there was a high rate or frequency of microfoci of prostate cancer. And so the fear as high as 50% in men 50 and older. And so the fear was that if they got testosterone, prostate cancer that was already present would grow like wildfire. And so that was the problem. I started out doing some sexual medicine as part of my specialization within urology. And the problem is we didn't have very much to offer those men. Viagra, Cialis were not available yet. And because of my experience with the lizards, I started offering testosterone to some men really just to see what would happen. And of course, many of these men responded well, as all of us, all of you probably on this session probably know about, which is why you're here and learning about it. Testosterone is effective in men in alleviating many symptoms: sexual, vigor, vitality, muscle, fat, mood, in men who have low levels. But it was a little bit scary for me because although I didn't know what was happening in the world at large, I certainly knew that in my area where I was practicing medicine, Boston, which is considered a medical hub, area of excellence within the United States, nobody was doing this. My patients would go for second opinions or come back to me, or they would have other doctors. And after I'd recommended a trial of testosterone, they said, my doctor, and many of these were very famous people who I knew and respected, they'd come back and they say, this stuff, they say, you're crazy to recommend this. It's going to cause prostate cancer and it doesn't work. So I was a little bit nervous. The treatment I was offering deviated from standard practice at that time because these men were generally healthy. They didn't have any overt medical problems. They just had low levels of testosterone. They didn't have pituitary or hypothalamic issues. Most of them had two relatively healthy testicles, most but not all. And they were middle-aged and older. And so this prostate cancer issue was paramount for me, and I didn't want to do anything bad for these men. And so to help them and to help me to a certain extent, so I didn't have to worry about them as much, I started offering, frankly, insisting on doing a prostate needle biopsy before I gave testosterone. I needed to rule out as best we could the presence of prostate cancer that in my mind would grow rapidly if we gave these men testosterone. So I started doing that in 1992, and right away we found cancers. And we presented our data when we had like 6 cancers, I believe it was, out of the first 33 men. We presented at our national urology meeting, the AUA, and that was a high rate we had 6 out of 33. It was a high rate of cancer. And one of the most famous individuals at the time internationally, Bob Crane, was the chief at Boston University, who had this huge booming voice, came to the microphone at the end of the abstract, and he said, "This is garbage. Everybody knows high testosterone causes prostate cancer. Low testosterone is protective. You guys stuck your needles places you never should have stuck them. And I bet you dollars to donuts, you'll do another 100 biopsies and you won't find any cancer." So we thanked him. What can you say? We're just reporting our data. But I kept doing it. And eventually we submitted this to JAMA, the Journal of the American Medical Association, when we had more cases. And they published in 1996 this figure from that paper. And what we were reporting very simply was that we found 11 cancers in 77 hypogonadal men, so 1 in 7, all with a normal PSA and a normal digital rectal exam. The rates for our current study is shown in the middle of that slide in white with a rate of 14.3% positive biopsy rate. Now remember, the belief at the time was that low testosterone should protect men against prostate cancer. And the belief was, just like Dr. Crane had when he came to the microphone to criticize our paper, was that these men should have a nearly zero, or a rate of cancer approaching zero, because the belief was they'd be protected by their low levels. What you see in this figure is that the studies listed below were prostate cancer positivity, percent of biopsies that showed cancer, in men who either, in large series, in men who either had a positive digital rectal exam, a nodule or something like that, or an elevated PSA between 4 and 10. The studies that are shown above it are men who had a normal PSA but had biopsies for some reason. And so what we were doing was actually doing biopsies in men who had no reason to get a prostate biopsy, but we're only doing it because their PSA was normal. We're only doing it because I was anticipating giving them testosterone, and I needed a negative biopsy before I would do it. So the end result of this was our finding, and we confirmed it in a larger subsequent study of 345 men, is that if a man with a PSA less than 4, normal, but has low testosterone, and you do a biopsy on him, there is a roughly 14 to 15% chance, 1 out of 7, that you will find biopsy detectable prostate cancer. In other words, The training that low testosterone was protective did not appear true. And I would argue that this rate of cancer in our population was really rather similar to the rate in men with known risk factors. So that was 1996. I kept doing biopsies, mainly because I still worried that high testosterone was a problem for these men. And I didn't want them to have prostate cancer before I gave them testosterone. But low testosterone, in my mind, clearly was not protective anymore. I worried about high testosterone, and I worried about it until with my fellow Hernani Rodin, who's now a prominent urologist in Brazil. He was my fellow at the time, until we wrote a review article for the New England Journal of Medicine, shown here, 2004, on the risks of testosterone, in particular, the risks of prostate cancer. And we reviewed several hundred articles. And in the end, we were a little nervous about this, but in the end, what we found and we published is that the number of articles in the PSA era, which dates roughly back to about 1985, that showed some worrisome relationship between testosterone and prostate cancer, either with testosterone trials or testosterone therapy or just high levels of endogenous testosterone. The number of those articles was 0. Even though this concept was taught around the world to students and to residents and to faculty, we simply could not find any evidence in the PSA era to support it. And there were dozens of papers that were trying to show this, but they were unable to. It was remarkable. So I needed to go back to the source and find out, where did this original prohibition against testosterone therapy come from, at least with regards to prostate cancer. And in urology, all roads lead to Charles Huggins, who was awarded the Nobel Prize in 1966. But his original work was in 1941. And at the time, there was no known treatment for men with metastatic prostate cancer. And based on some work he had performed in the laboratory on dogs, he took a series of men with bony metastases, and he castrated them. He removed the testicles, or in some cases, he treated them with high-dose estrogen, which also lowers testosterone. And he showed that another marker, this is before PSA, it was called acid phosphatase, prostatic acid phosphatase. He showed that those numbers went down in the men. It was elevated when they had the cancer, and it was reduced when they did castration. And we still do that today in one form or another. When I was in training, we still removed the testicles, bilateral orchiectomy for these men. And then we come up with medical castration now, these LHRH agonists. And here we are today in 2020, and we still use the same treatment, more or less, that Charles Huggins and his co-author Hodges were discussing and presenting data for in 1941. It's almost 80 years ago. In addition, however, they wrote that they gave testosterone to some of these men, and that in all cases, the acid phosphatase increased. So if you replace in your mind acid phosphatase with PSA, you get the idea that there's been some progression. And their final concluding sentence in this paper is, as shown on the left in the first bullet, cancer of the prostate is activated by testosterone injections. It's incredible. To find this paper before we had everything you can find online, I actually had to go down into the bowels of the medical library at Harvard Medical School, Cantway Library. And in the basement, they have the old archives, all these bound volumes, like Lancet goes back to the 1800s. And I had to pull this off the shelf, and I still can feel in my body that experience I had reading that article, because I got terribly nervous. My palms were sweaty, because here was Charles Huggins, probably the greatest urologist of all time, saying that testosterone injections activate prostate cancer. And by this time, I had quite a few men on testosterone, and I had visions of the Harvard police coming and taking me away, or my patients ending up with prostate cancer and my being responsible for that in a terrible way. And after a moment passed where I saw my life and career passing from me, I told myself to read the article again and get some specifics. And what I found was, I asked myself, how many of these men actually got testosterone? You know, papers were written a little bit differently then. They were more anecdotal. They were more storytelling almost. And it's harder to just get that data. But what I discovered is that only 3 men in that group received testosterone. It was testosterone propionate back then, and it was given daily. And all of these men received it for only 14 days, which is not a very long time. Of the 3 men, results were only given for 2 of them. One of these men was already castrated, which today we would put in a special category, and we would call that androgen deprived. Therefore, the general rule that they were stating, that cancer of the prostate is activated by testosterone injections, was really based on just one man who hadn't yet been hormonally manipulated. And the results were there for only 14 days, and they go up and they go down before treatment, during treatment, after treatment. It is unintelligible. And that was the basis, and is the basis, ladies and gentlemen, for our fear still today that testosterone activates prostate cancer. That was the origin of it. So I just put out a couple of cases here, just sort of to focus us. Does testosterone therapy increase the risk of developing prostate cancer? A 53-year-old man comes in with low libido. His erections are unreliable. He's tired. His labs show low levels of testosterone. Everything else seems normal. And we discuss with the patient the possibility of testosterone therapy helping him. And the patient has a question. Doctor, will testosterone increase my risk of getting prostate cancer? Well, we actually have some data on this. Let's start just with understanding that testosterone is a natural hormone. We all have it, men and women. And what's really happened is as we get to a certain age, our levels drop to a point where we become symptomatic. And the goal of treatment is just to restore our testosterone to normal. One of the beautiful things about the fact that testosterone is a natural hormone is we can measure it in individuals, and we can look at men who have higher levels compared to sort of the average and men who have lower levels compared to the average. And we can get important data just from endogenous testosterone levels. And so we have these longitudinal studies where we can look at individuals over many years. There are any number of these, San Bernardino, and others, and from all over the world. This is a study published in 2008 that pooled together the data from multiple studies. They had together over 3,000 men with prostate cancer, over 6,000 age-matched controls. And what you see here in the figure is that they looked at several androgens, testosterone, free testosterone, DHT. They broke them into fifths, the lowest values, lowest 20%, highest 20%. And they looked at the relative risk of developing subsequent prostate cancer. I think you can see here that there's nothing going on here. Men with the highest levels of testosterone have no greater risk of developing cancer than men in the lowest 20%. And this is true for all of these. DHT looks interesting, but you can see that the hazard ratio of 1.0 is crossed and is not significant. We have 19 placebo-controlled studies at the time of this paper. They have more now that looked at the rates of developing prostate cancer. This is one that reviewed 19 of these. And there was no difference for prostate cancer rates, PSA greater than 4, or urinary symptom scores for men who received testosterone compared with men who received placebo. And now we have access to what we call big data. These big data sets, they're observational data, but they can be very helpful. And this is one that came out of a University of Toronto group, Wallace et al. They had over 38,000 men, 10,000 plus who had received a testosterone prescription, 28,000 who had not. They have a median follow-up of 5.3 years. And what they found is that the 5-year cumulative incidence of prostate cancer diagnosis was 3.2% for the controls and a lower rate, 2.8%, for men who got testosterone. And you see here controls in terms of the higher numbers means the frequency or the rate of getting the diagnosis of prostate cancer over time. And you see that the testosterone treated men have a lower risk. Amazingly, they took this a step further and they separated men out according to how long, the duration of time they had been on testosterone. And you see that down in the lower right. And it turned out that the longer the duration of testosterone therapy, the lower the risk of developing prostate cancer. Amazing data. So I think we can answer that question that being on testosterone does not appear with the data that we have so far to increase the risk of developing new diagnosis of prostate cancer. Next question is really, and this is sort of almost a philosophical one, since lowering testosterone is used to treat advanced prostate cancer, how is it possible that raising testosterone doesn't increase the prostate cancer risk? So let me start answering this by going back to normal prostate. Normal prostate and prostate cancer are both androgen sensitive. They have the same kinds of responses. Whether normal prostate is a perfect example for prostate cancer is arguable, but the concept of how this tissue is using androgens is similar. So this is a study in human volunteers. They did not have prostate cancer. Shally-Basine et al. Published up here 2001. And what they did is they took men and they lowered their own endogenous testosterone with LH-RH agonists, so they're not making any of their own testosterone. And then they had different groups who got weekly injections of testosterone at extremely low doses, quite low doses, 50 milligrams, 125 weekly, which is roughly replacement therapy, and then supraphysiologic doses of 300 and 600 milligrams. What you see in blue, using the scale on the left, are the testosterone values at week 16. And you can see that some of these groups here in the United States are values 1,000 nanograms per deciliter, upper limit of normal. Some of these men were more than 2 times, almost 2.5 times the upper limit of normal for several months. What happens to PSA, shown in red, and what you see here is that the PSA doesn't change, measured at week 20. It's as if the prostate, in terms of its production of PSA, doesn't even care what level the testosterone is at. And so in the past, our belief was, both for benign prostatic hyperplasia and for prostate cancer, was that more and more testosterone leads to more and more prostate cancer growth. So if we plot serum testosterone here on the x-axis, prostate cancer growth by whatever you want to measure it by on the y-axis, the curve goes on and upwards and upwards to infinity, whether it looks like this or like this, indeterminate, but more and more testosterone, more and more prostate growth. And in fact, what the data show, and the study by Shally-Basine I just showed you, where they got supraphysiologic testosterone, what the data actually are consistent with is that at very low concentrations of testosterone, again, we're plotting testosterone against PSA or prostate cancer growth, at very low concentrations, there is indeed a dose response curve. But at some point, the prostate becomes saturated. It's had enough testosterone or androgen, and at that point, it just plateaus. And so higher and higher testosterone does not increase prostate growth, PSA, or anything else related to it. And I think most of you, I think this will make perfect sense if you understand how this works physiologically. This is a cell, let's call it a prostate cancer cell. It's got a lipid bilayer. Here is free testosterone, which is lipophilic. It crosses that lipid bilayer easily. And then it binds to it's reduced by 5-alpha reductase to become DHT, which is the preferred form of androgen within the prostate cell. It binds to the androgen receptor, either as testosterone or as DHT. And then here you have it. And then the complex of androgen with androgen receptor translocates, it moves into the nucleus, it binds to androgen response elements on the DNA, and then transcription is stimulated, and everything that the cell wants to make that is androgen dependent in the form of RNA is made, and then it goes on and it does what it needs to do. The important points is what does not happen. It is not free testosterone or free DHT that comes in here. It is not the androgen receptor unbound to androgen that comes in here. It's this complex. And so you can imagine that we have a finite, limited number of androgen receptors per cell. And once all of these are maximally bound to androgen, adding additional androgen does not have a mechanism in this way to augment the response of that cell. Hence, the term saturation. And if you look experimentally, these are 3 lobes of the rat prostate shown here. If you look at specific binding of androgen to the androgen receptor, what you see is that at very low concentrations, this is nanomoles per liter, you see there's a steep curve around 2 nanomoles per liter, and then it plateaus. Steep curve, plateaus. Third lobe, steep curve, and then it plateaus. And that's it. Becomes maximal binding in the rat. Anyway, occurs at 2 to 3 nanomoles. Rats do not have sex hormone binding globulin, and it turns out that the values in men is about a little bit more than double that, and the saturation point is roughly 8 nanomoles per liter or 250 nanograms per deciliter in the man. And so the old idea that testosterone is like food for a hungry tumor, I would suggest that we switch it. And I would suggest that the more appropriate term is that it's like water for a thirsty tumor. When you have too much water in your body, if you're drinking too much right now, you are going to eliminate it. You get to full hydration and that's it. Imagine a house plant. This is a nice Christmas plant for this time of poinsettia. But imagine a house plant that needs water. And the house plant represents cancer. The water is testosterone. If you deprive it of water, it will shrivel and shrink. It'll lose mass. It'll lose volume. If it's still alive and you water it, it'll grow. It'll gain mass. It'll gain volume. But once this house plant has enough water, you can have a garden hose running into it 24 hours a day, and that house plant will never grow to be the size of a giant tree because it's satisfied its ability to use that nutrient, if we can call water a nutrient. So it turns out then that this is very important ideas in how we interpret PSAs, because it turns out that PSA concentrations are androgen dependent, but only below the saturation point, which is approximately 250 nanograms per deciliter, or in nanomoles per liter, it's 8. And so although testosterone therapy can cause the PSA to rise, it's actually more accurate to describe it or think of it that the low testosterone seen in men with testosterone deficiency or hypogonadism have a falsely depressed PSA. And that when we normalize their testosterone and PSA rises, that's actually their normal androgen replete PSA value. So when testosterone therapy normalizes, the PSA becomes androgen replete. That's the real value. And so to correctly interpret PSA, you have to know whether the serum testosterone is above or below the saturation point. Question. Clinical case, can you offer testosterone therapy after radical prostatectomy? Our training until very recently has been absolutely not, and the labels, product labels, will all say that this is contraindicated. But times are changing. This is a 64-year-old man presents to you. He's been on testosterone for 3 years, and he's diagnosed with intermediate grade prostate cancer, Gleason 7. Testosterone therapy is discontinued, which is what almost always happens. He undergoes robotic radical prostatectomy. His pathology, again, confirms the original pathology of Gleason 3+4, which is intermediate risk. His margins are negative, seminal vesicles and lymph nodes are negative. And at 3 months, his PSA is undetectable, which is our best possible result. Low risk of him ever having recurrences. It's not zero, but low risk. And he now says, doctor, I felt so much better when I was on testosterone. Can I go back on it? And what do we say? And we really used to say, and still most of us say, no, you can't. It's dangerous. But we now have some evidence. None of these are randomized controlled, but some of them have comparison groups. So let's be cautious in interpreting these, but we do have some case series. This is the largest so far from this year, Tom Allering at the University of California at San Diego. Irvine in California. Single center, 152 men with low testosterone were treated after their RP stands for radical prostatectomy, surgery for prostate cancer. 152 got testosterone, 419 men did not after surgery, mean of 3.5 years of follow-up. And look at the biochemical recurrence. Biochemical recurrence, for those of you who aren't urologists, means that the PSA has come back to some detectable value. And since the only thing that makes PSA is prostate tissue, either malignant or benign, that means there's some prostate cancer cells that are still in the body. And that's what biochemical recurrence is. If it grows enough to be detectable by imaging, you can find like a node or something like that that's enlarged. That actually then gets defined as metastatic disease. But in terms of biochemical recurrence, which is the first thing, men who received testosterone had a rate of 7.2%, and the men who did not receive testosterone was 12.6%. I left out the p-value by error, but it was statistically significant. And it also turned out that testosterone therapy was an independent predictor of recurrence-free survival. That's what you want. You want to be recurrence-free. Here's another study out of Baylor in the Houston area in Texas, 103 men. 26 of these men who got testosterone, T therapy, TTH, were high risk. They had high-grade cancers, Gleason 8 to 10. They had positive margins, and at least one of them had positive lymph nodes. There was a comparison group of 49 men who had normal testosterone, did not receive testosterone afterwards. 15 of those men were high risk, median of more than 2 years follow-up. And biochemical recurrence was 4% in the men who got testosterone, 16% in the men who did not. These authors, nor anyone else, is claiming that it's protective against the recurrence of cancer. Again, these aren't controlled studies, but I think certainly, and we have a number of studies like this, certainly the evidence is very reassuring that testosterone therapy is not causing some massive rate of regrowth or just growth of remaining prostate cancer cells. This is brachytherapy. These are radioactive seeds that are placed in the prostate as treatment for localized prostate cancer. This is 20 men. This Bonton et al. T therapy was offered in these men for symptoms of low testosterone, median follow-up of 31 months. And the SHIM score improved in these men. The SHIM score is a questionnaire that looks at sexual function, had nice improvement, which is why the men wanted to be on it and stayed on it. And in not one of these men, now it's a small group, just 20, but not one of these men demonstrated progression. So this may seem counterintuitive to you, especially if you were trained, as I was, that testosterone therapy should never, ever, ever be offered to men with a history of prostate cancer. So let's do a thought experiment. I want you to imagine two brothers. Let's give them the same genetics. They're identical twins. Let's say they're 60 years old. They undergo surgery for low-risk prostate cancer, but the most common kind, Gleason 6. At 12 months later, the PSA for both is undetectable, which is what we want, best possible result. Brother one comes in for his annual visit. He's happy. He's sexually active. His testosterone is 600 nanograms per deciliter, roughly 20 nanomoles per liter, very normal. And what does the doctor say to him? We say, you're doing fantastic. This is the best possible thing. Listen, I'll see you back in a year. Have a good year. Second brother comes in right after him, and he's tired. his libido is down. His testosterone is 250, about 8 nanomoles per liter. And he says, doctor, how about some of that testosterone? I've been hearing about it. I think maybe that'll help me. And what does the doctor say? Say, well, I can't give you testosterone. It's dangerous. And brother 2 says, what will happen? And the physician says what we've always said. I said it myself for a long time at the beginning of my career. I said, and we say, it'll make your cancer come back. And brother 2 asked a question that urologists from my vintage never really asked, which is, why is it all right for my brother to have a testosterone that's well in the normal range, 600, but not me? Doctor, I love my brother very much. If you think it's dangerous, I'm going to bring him right back into this office, and I want you to lower his testosterone until he feels as poorly as I do. Well, when I say this to live audiences, I can't see any of your responses, but usually that's my big laugh of this of this session, because especially for urologists who treat men with prostate cancer, because we've all learned, no, I can't do it. No, I can't do it. It's dangerous. It's dangerous. But when confronted with the idea of it, in very practical, familiar terms, if a patient has level, his brother is a higher level, it actually seems ridiculous. We don't do that. We don't lower the testosterone in men with normal testosterone because there's no evidence that it would help. And it just doesn't make sense. We learned a very simple idea a long time ago, which is that more testosterone is worse for prostate cancer. And we didn't learn any of the nuances about it. So let's take this a bit further. Can testosterone therapy be offered to men on active surveillance? Active surveillance for the non-urologist is when men have relatively low risk prostate cancer, or Gleason 6 usually, and they don't have a large volume of it. And so instead of operating on them or treating them with radiation, we just keep an eye on them. We get a PSA a couple of times a year, and they usually get a follow-up biopsy at 12 months and then at different periods thereafter. MRI is starting to come into the protocols, but that's what we've been doing now for a number of years. And so these men have active prostate cancer, and about a third or more will eventually have higher grade cancer and go on to treatment. Here's a case of a 68-year-old man with Gleason 6. He has 2 foci of the cancer in his prostate. He had a repeat biopsy which showed something similar, all of which means that he's a reasonable candidate for active surveillance. But remember, that means he's got cancer and he has not been treated. He has symptoms of erectile dysfunction. He has difficulty achieving an orgasm. His mood is blunted, and his serum testosterone is low at 220 nanograms per deciliter, or 7.3 nanomoles per liter. And he says, doctor, is it safe for me to try testosterone therapy? Well, here's some relevant data. The first study on this was a group of collaborators and myself published in 2011, just 13 men who were on surveillance, and we gave them testosterone. Median duration of therapy with testosterone was 2.5 years. All of these men had follow-up prostate biopsies, an average of 2 sets of biopsies per person. All the men experienced symptomatic benefits from the testosterone, And we didn't find a single case in these 13 men of cancer progression. This was shocking at the time. And here's from that paper is a figure of what happened to their PSA during testosterone therapy. 0 time here, this is in months. 0 was when their cancer was diagnosed. You see their PSA value. And then this is 3, 6, 12, and 24 months after beginning testosterone therapy. And you can see that the PSA did not rise in these men. Shocking for us. This is how it works, though, and if you understand the saturation model, it'll make sense. This was one of those gentlemen. This is 2007, October, when he first came to see me. This gentleman made very little testosterone on his own. He'd been on testosterone injections for something like 10 or 15 years. And when his PSA rose above 6, he underwent a biopsy. It showed cancer. It was Gleason 6. He declined treatment, but his doctor said, I can't give you testosterone anymore. He went from doctor to doctor to doctor around Boston until somebody suggested he see me. I was nervous about it. This was really early in my experience doing this. And I said, well, okay, but you understand your cancer could grow rapidly. You could get complications. You could die. And he was willing to do it. But I want you to see what happened to his PSA curve. When I saw him, he had been off testosterone now for about a month. His testosterone was only 64 nanograms per deciliter, which is about 2 nanomoles per liter. Almost in the castrate range. And what had happened to his PSA, it had dropped from 6.4 or so down to 2.3. I gave him testosterone, so he's below the saturation point, and his PSA increased until May here, so that's about 6 months, and then it plateaued, and the end of this is 2009. Now, this gentleman died a few years ago, but he was on testosterone for almost 10 years and never developed, never got treated for his prostate cancer, and he died of something totally unrelated. He had was on dialysis and had myelofibrosis. So here's another study we published just from my own center, 28 men on active surveillance, Gleason 6 in most, but we had higher grade cancers in 6 of these men also. And we compared them with my colleague at my institution who had 96 men on surveillance, also with low testosterone, but he didn't offer testosterone therapy. And we looked at progression rates, and we had over a 3-year follow-up. And you can see here the progression rates are almost identical. And again, PSA did not rise in the men who got testosterone with prostate cancer. A couple of years ago, we presented at the AUA. We have not published this as yet. We collected 190 men who have a diagnosis of prostate cancer who we've treated with testosterone. You see here 86 men with after radical prostatectomy, 49 at the time after external beam radiation or brachytherapy, which are the radioactive seeds. 47 men at that time were on active surveillance. Their ages are here. Mean follow-up for all is about 4 years or a little bit more. And here the number of recurrences or progression. And here's the rate of recurrence or progression. And you can see the numbers here. And these are the rates in the literature for a large series of men who never got testosterone. And I think you can see that all of these rates from our patients compare favorably with published rates of recurrence. Again, these aren't controlled studies. I'm not saying to you that the rates are lower. I'm just saying that what this doesn't show is some huge increased risk of prostate cancer recurrence or progression. Well, what about the experience with testosterone flare? Doesn't that prove that even transient increases in serum testosterone are dangerous? Remember that testosterone flare is what happens when people get initial treatment with LHRH agonists. After about 7 to 10 days, the testosterone drops, but initially there's a rise in testosterone. That's called the flare. And when the LHRH agonists were introduced in the late 1980s, there were some reports of people with prostate cancer having bad outcomes, and it was blamed on this rise in testosterone, the testosterone flare. And so the question is, are we fueling a fire with this? This is a paper that was published in New England Journal of Medicine in 1989, and at the time totally missed, there was no comment and no recognition of its significance with regard to testosterone flare. What it did is it compared men with metastatic disease, 36 of them, with exceptionally high PSA levels. Average was around 500. And they had two groups, one that got an LHRH agonist alone. So for the first 7 days or so, the testosterone's increased. And the other is they used an anti-androgen with the agonist. And you can see that PSA drops very quickly with them. But it takes a while before the PSA drops. Eventually they get near or to the same. If this went on, they'd get to the same place in terms of this is change in PSA. But what's important about this that nobody commented on is that during the rise in testosterone, this is PSA, there's no accompanying rise in PSA. It just stays flat. Just like that study I showed you where men were getting supraphysiologic doses of testosterone and the PSA never rose during that time. This is another paper, the same design, no increase in PSA with testosterone flare. Eventually it drops. And there you have it. I think the testosterone flare concept is contradicted by the evidence and the understanding of why is the saturation model. Well, let's take it even one step further. Can testosterone therapy be offered to men with metastatic prostate cancer? Remember that we treat these men with androgen deprivation. And androgen deprivation has been shown to shrink masses from metastatic masses, to improve pain with bone metastases. There is a real, quite enormous literature showing benefits, at least short-term, with androgen deprivation. I want to show you this case. This is a real case. This 94-year-old gentleman came to see me. He was a scientist. His brain was still sharp. He came with his daughter, who was a nurse practitioner, which in the United States is, they have full prescribing rights. They're almost, they need some medical supervision, but they're almost independent. Very savvy woman, mature woman at the time of this. Father's 94. And he had a terrible prostate cancer. He had Gleason 9. For those of you not familiar, Gleason 10 is the worst. We almost never see it. He had diffuse bony metastases. His ureters bilaterally were blocked, and so he had nephrostomy tubes. His PSA was higher than 500. And he already had been treated in the past with androgen deprivation. He stopped it at 6 months. He felt he was just too weak to walk. He never got out of the house. He was miserable. So he comes to see me and he says, I'd like you to treat, I've read your work. I'd like you to treat me with testosterone. Well, I'd never treated anybody like this. And I said, well, what do you want to be, what do you want? Like, what are you hoping for? He said, well, you know, I used to feel good when I exercised every day, and I'm too tired now. I have communications and correspondence with fellow scientists and colleagues around the world. I'm just too tired these days to do it. I feel like my brain isn't so sharp. I said, this could kill you. It could kill you tomorrow, in a week, in a month. He said, Doctor, I've never lived my life in fear, and I don't intend to now. He said, I know I'm going to die of prostate cancer. I'm 94 after all, too. I'm going to die of something, probably prostate cancer. So while I'm still on this planet, I'd like to live as well as I can. And that's why I'd like you to treat me. I'll sign whatever form you want me to sign. I understand I can die. So I treated him. Where did he go? There he is. And at 7 months, his daughter sent me this picture of him, which I show with both of their permission. He was feeling great. This is in the waiting room of the dentist's office. At this time, he was 95. He was getting testosterone injections, high dose, every 2 weeks. And the high dose is because there's some data that high dose testosterone may actually inhibit prostate cancer. Almost immediately, within a very short time, his brain had become clearer. He was exercising daily. His appetite improved. He was working on his next patent. He never had bone pain. He died at 11 months. His PSA was over 2,000. But until the very end, he stayed on testosterone, and both he and his daughter were thrilled and delighted with his quality of life. And he encouraged me not only to share his story, but to keep doing this type of work. What I want to show you is, I'm going to go back for just a quick second. These are data. I think I'm running late, so I won't spend much time on it. But I mentioned to you, this is in vitro data. I mentioned that high-dose testosterone appears to be inhibitory for prostate cancer. So these are cell counts of LNCAP cells. They're grown in the lab. They're prostate cancer. They're androgen sensitive. And they're grown at different concentrations of androgens. And you see here the concentrations start from very low, left to right, to sort of physiologic and then supraphysiologic. And if we restrict ourselves to the beginnings, these are different amounts that were put on the plate, different numbers of cells, but they're all the same results. You can see that the numbers go up if we were to just limit ourselves to that. But beginning to enter into the physiologic range, the prostate cancer cell growth is inhibited all the way through into the supraphysiologic range. It's amazing. And taking advantage of this is a remarkable experience headed out of Johns Hopkins with Sam Denmead Oncology Group, where they did something which they call bipolar androgen therapy. It's called bipolar because what they do is they put men on LHRH agonists, which is standard therapy. Men don't make any of their own testosterone. And then once every 4 weeks, they get a single injection of high-dose testosterone, 400 milligrams of testosterone cypionate. Their testosterone levels become supraphysiologic, and then they drop back down into the castrate range before their next injection at 4 weeks. So they go from supraphysiologic to castrate. That's where the term bipolar comes from. And what they showed is in many of these men, this is a study of 16 men, the PSA, the nadir PSA dropped in about half of the men. And they had several men who had nodal disease. This is before treatment. After 3 cycles, it's smaller. Same thing here, it's smaller. They actually showed regression of these masses. Remarkable. And that was the basis, in part, the in vitro data and the bipolar androgen therapy that encouraged me to use high-dose testosterone in these men who I treat. Recently, I published what I call modified bipolar androgen therapy. Instead of every 4 weeks going through this cycle, the men stay on testosterone at high doses for a total of 8 weeks. And then for 4 weeks, they're on an anti-androgen, which brings their PSA down. And what you see here is PSA in blue. Testosterone is in whatever color this is on your screen, orange or red. And you see that the PSA goes up with the testosterone, comes way down, goes up, comes way down with each of these cycles. This gentleman was on modified or MBAT for approximately 2 years and did very well. And of course, during the 8 weeks of testosterone, he felt great and was active, sexually active, made a big deal for him, a big difference for him. So nearly everything that we learned about testosterone and prostate cancer was wrong. And if we go through the questions, the answer to all of these is no. Does high endogenous testosterone increase the risk of prostate cancer Does testosterone therapy increase the risk of prostate cancer? Does testosterone therapy increase the risk of biochemical recurrence after radical prostatectomy? Does testosterone therapy increase the risk of progression in men on active surveillance? Does testosterone flare cause exacerbation of metastatic cancer? Does testosterone therapy in metastatic disease necessarily cause rapid progression and death? The answer to all of these are no, but I need to put in an important caveat. All of these studies, for the most part, are observational. We have very little in the way of randomized controlled trials. I showed you some data on meta-analysis of randomized controlled trials in development of prostate cancer. Those numbers are becoming better in terms of the development of prostate cancer, and I think we can say with high degree of confidence that it doesn't do that at this point. But we used to believe that the answer to all of these questions was yes. And the change has happened really just over the last 10 to 15 years. So this is what I do. I'm not saying you should do it. I think there's a certain degree of medical legal risk. And in some countries like the US, that risk may be substantial. I think we have the highest rate of lawsuits in the world. For radical prostatectomy, I begin testosterone therapy if they're appropriate candidates as soon as the PSA is undetectable, usually by 3 months. For radiation or brachytherapy, I do the same. I begin once the PSA is low. In those cases, the PSA is still usually measurable, but it's low. It's reached its nadir. Active surveillance, I think you can begin anytime. Note that the PSA will rise over the first few months if the testosterone started below the saturation point. If it started above the saturation point, it probably won't change. Biochemical recurrence after surgery or radiation, I think you have to use extreme caution. A significant number, all of these men, probably given enough time, will actually end up with metastatic disease or may die with or without testosterone therapy. It's just the natural history of the disease. But if you give testosterone, most of your colleagues will say that your testosterone treatment caused it, and you could have a problem there. So I'm giving you a little bit of our experience with this, but I'm not at all recommending that you offer this treatment. And I would say the same with double lines of emphasis underscoring this for men with metastatic disease. You know, men with metastatic disease really are at risk of death and within a limited period of time. Some will live for quite a few years, but the PSA will continue to go up, whether they're on testosterone or not. But I now offer modified BAT to selected men, and we've got a manuscript in preparation now where we have about 20 of these men, and we saw no precipitous adverse events. So why do we still fear testosterone? And I think Charles Darwin had a comment in his book, The Descent of Man from 1871, that I think is appropriate and relevant for this, even though he wasn't thinking about testosterone and prostate cancer. He wrote, and I quote, "It is worthy of remark that a belief constantly inculcated during the early years of life, while the brain is impressible, appears to acquire almost the nature of an instinct. And the very essence of an instinct is that it is followed independently of reason." In conclusion, our original prohibition against testosterone therapy in men with prostate cancer was based on the weakest of evidence and simply went unchallenged for decades. Current evidence supports the saturation model with a saturation point of approximately 250 nanograms per deciliter or 8 nanomoles per liter. We have a limited yet uniformly benign experience with testosterone therapy in men who have undergone successful treatment of localized prostate cancer and in active surveillance. Active surveillance, the numbers are still quite small though. And testosterone therapy in testosterone deficient men clearly offers a variety of health and symptomatic benefits, including improved quality of life, such that even if there might be a small risk with prostate cancer, we always have to weigh benefits versus risks. At this time, the risks remain theoretical as much as people have believed them for decades. I want to thank you for your attention for all that. And before I sign off and turn this back to Professor Jones, I just want to offer you this. If you're interested in testosterone, we're offering what I think in the United States is the only full-day course on testosterone therapy. The website is here at the bottom, hmstestosteronecourse.com. HMS stands for Harvard Medical School, if you don't have time to write it down. hmstestosteronecourse.com. Abdul Traish will be also a wonderful speaker, will be doing this with me. Thank you very much.
Hey, thank you. Is it back with me? Yes, thank you very much for the talk. That's great. It's very comprehensive and very clear. We've got a number of questions, so I'm going to pick a few for you, Abe. So first of all, we have a doctor who is going to start a patient on testosterone who is on active surveillance for his prostate cancer. So he's asking whether or not you should begin with a gel as its short action, or does it not matter? What would you use as your testosterone replacement of choice?
So this is a very common question. And it's one that used to, when I and some of my colleagues started doing this work of very tentatively offering testosterone to some of these men, that we really wrestled with. Exactly for the reason you're talking about. Wouldn't gel, a short-acting preparation, be advisable? Because if something terrible happened, PSA went up, you could just stop it. As it turns out, and our experience has been so benign, that at this point, I don't think it matters. And I just treat the man in the best way I think possible for him. You know, we have a number of testosterone preparations that are available. I think gels are fine and great. And if that's what you want to do, go ahead and do it. And if you want to do something else, I think it's also fine. Nothing happens suddenly in these men. As a matter of fact, we don't even usually check the PSA after we've started this for at least a month, and usually 2 to 3 months.
Okay, thank you. Another question is, what data exists concerning the role of hypogonadism and the immune system activity? I should think that's from relation whether or not it helps the prostate cancer.
What an interesting question. So Abdul Traish, who I just mentioned, who's going to be giving that course with me on testosterone, is the lead author on a paper that reviews testosterone and inflammation in the body. I don't have the reference for you, but it should be easily found. Traish is Traish, Abdul, and testosterone inflammation. It's marvelous. And it turns out that testosterone appears to stimulate the immune system in positive ways, and also to diminish some of the negative aspects of the immune response. So IL-6, which is implicated, for example, in cytokine storm, which comes up with COVID, severe COVID infections, appears to be depressed or suppressed by normalization of testosterone. In terms of the cancer, you know, it's arguable how much of prostate cancer is influenced by the immune system. Some people feel there may be a role, but that's not well established.
Okay, thank you very much. And there's a question here. Can a testosterone determination be regarded as a marker for prostate cancer beside the PSA? And I think that's really in your view of your hypogonadal patients. There's increased risk, I think.
I'm sorry, can you repeat the question?
It asks, can a testosterone determination be regarded as a marker for prostate cancer beside PSA?
Oh, I see. Also, so interesting. So it does turn out that men with high-grade prostate cancers, you know, we use this Gleason scoring system that runs, the low end is 6, the high end is 10. About half the cancers are 6s, and then most of the rest are 7s. And 8, 9, and 10 are aggressive cancers, but they probably only make up about 5 or 10% of what we deal with. But it turns out that if you take groups of men with Gleason 6, men with Gleason 7 is a separate group, and then you take those fewer, let's call them rare, but aggressive cancers, Gleason 8 to 10, you find an inverse relationship with testosterone. Testosterone is highest with the low-risk cancers, and it's depressed progressively with the higher grade cancers. So one might say then that low testosterone is associated with higher risk cancer, but it is not, to my knowledge, associated directly with the risk of having or developing prostate cancer.
Yeah, thanks for that. Then, what is your opinion? Can we today refuse rectal examination on testosterone therapy and leave only ultrasound in practice?
Yeah. So this comes up a lot, especially for those who are not urologists. Urologists are always doing digital rectal exams and prostate exams. The data there are no good data that show that the digital rectal exam is of value, of proven value in identifying prostate cancers. I remember when I was in my training, we were doing journal club and a paper came along that showed that in men who underwent prostate biopsy and had cancers based on an abnormal digital rectal exam, abnormal prostate exam, half the tumors were found on the side opposite of the abnormality. So you had a 50-50 chance of finding the cancer where you thought that it was amongst men who did have cancer. I think that the evidence, at least in the United States, is increasing, and many of the primary care doctors, general medicine doctors, are following this, is they're actually giving up on prostate exams, rectal exams. I think the evidence supporting it is now weak. The issue is that many of us with testosterone are trying to protect ourselves against the opprobrium of our colleagues who may frown on testosterone in general, or oversight or regulatory groups. And along those lines, most guidelines for testosterone, almost every medical society that touches on testosterone has these: endocrine society, endocrinologists, urologists, sexual medicine. They all encourage the use of digital rectal exam. The place where this comes up is not only with your patients, but it also becomes a medical legal issue. So I've done a fair amount of medical expert witness testimony and consulting in the United States for failure to diagnose prostate cancer. It's usually the case. Failure to diagnose it in men who receive testosterone. And what the attorneys do for the plaintiffs is they find all the ways in which the doctor failed to meet whatever guideline recommendations there were. So did they get 2 levels beforehand? Did they do a prostate exam is one of them. And if they haven't done that and documented, it sort of becomes like a check mark against them. It may not be the entirety of why they may or may not lose a case, but it's just one more piece of evidence. So, I think practically speaking, if you're not used to doing prostate exams, if you're not a urologist, frankly, I think it's okay to not do it. The yield is exceedingly low. For medical legal reasons, if you're in the United States watching this, I don't know how many viewers there are from there, it might be the right thing to do and to still document it.
I think the next question is sort of linked to this, COVID. So the question: in these COVID times, the most follow-up appointments are for men on testosterone are done via the phone. So there's no chance of doing a rectal examination down the phone line. Is this acceptable? So I think you've probably answered that, but COVID might be accelerating this diminution of rectal exams in these patients.
Yes, I think it is, and I think it is acceptable. It may, if you're worried about the medical legal environment, I think it's fine to say, televisit, rectal exam not performed due to COVID.
Yeah. Okay, good. So there's a question: how should hypogonadal men with advanced prostate cancer be managed? It's so I think that came before you explained the situation. So I think your talk actually explained that. Is there anything you want to add?
I would just add that standard therapy remains androgen deprivation. And I think to deviate from that, maybe for the reasons I showed you, may in some cases be improved quality of life, but entails a certain amount of courage on the part of your patient and a lot of courage on the part of the practitioner because if he's already got metastatic disease, he may very well die from it, and he may die soon. And you may be the last person to have done something that is believed to have encouraged that growth of the cancer.
Yeah. Okay. Thank you. So this question is: having been trained on the story of testosterone causes prostate cancer, your walkthrough history and debunking of myths is fascinating and liberating. I thought I'd put that in as just a comment. So yeah, it's a positive comment.
Thank you.
So it says, "Dear Professor Morgenthaler," this is the next one, is it warranted to treat a 48-year-old man who is symptomatic of testosterone deficiency, but his serum free T is normal? So that's looking at total against free T. It doesn't mention specifically in relation to prostate cancer.
So this is actually a highly controversial topic. And experts are divided as to whether total or free or bioavailable testosterone is more reflective of a man's androgen status. I will tell you quite freely, pun intended, that I'm a big fan of free testosterone. Total testosterone circulates in our body with roughly half of it, a little bit more, a little bit less, depending on the study, tightly bound to sex hormone binding globulin. That portion is not biologically active. And there's huge variation on the amount of SHBG that from one individual to another. And you can't tell by looking at somebody what their SHBG level is. You have to measure it if you want to know. But the point is that for men who have generous levels of SHBG, for any total testosterone level, that's getting measured, the part that's also bound to SHBG. But for any amount of total testosterone, the free testosterone or bioavailable will be lower, and in some cases truly low, if there's a generous SHBG, even in the face of a normal total testosterone.
Good. So another question is, most of the men who get androgen deprivation therapy for 3 years following radiotherapy become testosterone deficient for a long time. When would you start the testosterone replacement? When should testosterone be started in these men?
Yes, that's an important point for people to recognize, that the longer somebody is on androgen deprivation, the less likely it is for his own testosterone to recover to reasonable levels when it's finally stopped. And, I think people get mixed up about this. So it turns out that the results of radiation therapy for prostate cancer are better for intermediate and high-grade cancers, not low-grade, intermediate and high-grade cancers, if it's done with also a period of time of androgen deprivation. The belief is that the androgen deprivation acts like a radiation sensitizer for the radiation. And the periods can range depending on the risk of the cancer and the institution. It may be as short as 6 months. Common is a year. 2 years is also common, and sometimes longer, as you point out. Some of that has to do with the risk of the cancer. But even at 6 months, the number of men who will never recover their own testosterone is very high. And so the question is, if one is going to do testosterone, when should you do it? I think that whatever the benefit is of the androgen deprivation, whatever it's added to the radiation, I think that effect is done by 6 months. And if the man is interested and he understands the risks and the doctor's willing to explain and put in informed consent and all that, I think 6 months is a reasonable period to start it back up again.
Okay, that's great. We're coming towards the end. There's a couple of interesting questions just to finish off. What is the place of the androgen receptor polymorphism in order to anticipate prostate cancer behavior on testosterone replacement therapy? I think this is in relation to the more sensitive receptor that you have, the greater your risk of prostate cancer or association with prostate cancer. So what do you think about the androgen receptor polymorphism in this?
Yes, that's a very sophisticated question. I congratulate you. Whoever asked it is up on their reading. Yeah, I'm not aware personally of any data that's related to that at all, though, in terms of outcome. I don't have anything to answer with that, but certainly would be an interesting thing to look at.
Yeah, absolutely. Then, do you have any similar research on cardiovascular risk in testosterone use?
Yes. You know, I'm going to summarize a big field, if I can, in about 60 seconds.
Yeah.
The history of testosterone and cardiovascular risk for about 20, 30 years was uniformly showing that low testosterone was an increase for mortality, atherosclerosis, severity of atherosclerosis. Professor Jones has some lovely studies actually showing that intervention with testosterone in some cardiac patients with angina, with heart failure, actually the randomized placebo-controlled trials, that the men who got testosterone did better. In 2013 was published a study that got enormous media attention. It was not a randomized control trial. It was observational, and it suggested that the men who got testosterone compared to men who did not had greater risk of stroke, heart attack, and death. That study was complicated when its interpretation was complicated when it was revealed in response to letters subsequently that nearly 10% of the all-male population was female. It was a very bad study. Imagine a breast cancer study of women where you had 10% contamination by men. Impossible to interpret that. Since then, there's something we published a review about 22 papers, randomized controlled trials, most of which showed no difference in risk, not one of which showed increased risk with testosterone, and several showed decreased risk with testosterone. That's where we are today.
Great. Okay. The final question that we'll ask before and give you a rest is what drives the development of prostate cancer in testosterone deficiency? So that's, yes, probably a key question.
The truth is nobody knows. And not everybody would agree with the premise, which is that prostate cancer is increased with low testosterone. But I think there's enough evidence to strongly suggest it. If you won't laugh at me, I'll give you my thought on this. And I borrowed from a dear friend who's a researcher. Imagine that prostate cancer is like a bear in the woods. And he lives in an environment where there's plenty of berries and plenty of fish. He's happy. And he doesn't have to go very far afield. He gets all his nutritional needs satisfied within a very short radius. Imagine then that there is a deficit of berries and fish or whatever else it is that the bear eats. He's got to figure out a way to go further afield in order to get fed. What are the hallmarks of prostate cancer? It's mainly that it travels from one part of the body to another, although it can grow locally too, and grow and invade. And it seems to me that testosterone is required for these prostate cancer cells to grow optimally. And in circumstances where testosterone is very deficient, some of those prostate cancer cells may develop strategies like the bear that either require or involve, let's say, mutations, so that they develop the ability to do what we think prostate cancers do. Anyway, that's my simplistic way that I think of low testosterone and prostate cancer.
Okay. Well, that's a nice way to finish. Well, thanks, Professor Morgentaler, for your great talk and clarity and concise, accurate answers. So I think we'll close for this evening. I hope everyone has enjoyed and taken a lot of messages home and learnt a lot this evening. So thank you. Remember to fill out your evaluation forms, please, because that's quite important for our progress of these webinars in the future. So thank you for everyone for attending, and thank you to Professor Morgentaler for giving an excellent talk. Thank you. Good night.
Great to be with you.
Okay, thank you.